So Steve, it's on you. Go ahead.
Thank you. Uh, Everybody, I'm really pleased to introduce, and we're fortunate to have as our first online speaker in our combined Emeriti retiree after lunch program. Johnese, we usually had this at 1:30 in the afternoon. Johnese Spisso, she's president of UCLA Health. She's CEO of the UCLA hospital system and associate vice chancellor for health sciences. I need not reiterate to this audience the profundity of the events that have been caused by this COVID-19 pandemic, and the impacts of this event are as great or even greater on UCLA and especially the health system as they are on any of us in our individual lives. Today and in the coming months, we're going to see programs to help us to understand these effects and the way they will change UCLA as we know it. And most of us have known it for many years, in my case, nearly 50 years. Johnese Spisso received her bachelor's degree, a registered nurse RN degree, and finally her master's degree in healthcare administration, the latter at UCSF, at various California institutions. Starting as a nurse, she rose rapidly to senior administrative positions in healthcare. Prior to beginning her tenure here at UCLA, she spent 22 years at the University of Washington, my alma mater for genetics training, where she was Chief Health Systems Officer and Vice President for Medical Affairs. Ms. Spisso, as you can well imagine, has received numerous awards and accolades and has recently been an impressive and authoritative voice on CNN. And judging by the publicity put out this morning by the hospital, she's been involved in other venues as well. She has taken UCLA Health and UCLA generally by storm, and she is a dynamic and tireless leader and presence. She's accompanied by Robert Cherry, and the title of her and their presentation is COVID-19 Pandemic, an Inside View from UCLA Health. Johnese, please take it away.
Well, thank you so much. And what a pleasure it is for Dr. Cherry and I to spend time with your group this morning. We want to let everyone know UCLA Health is here for you for all your healthcare needs. And so we're just honored to be asked to present. What I thought I would do, and we definitely want to make this conversational, so we want to leave time for many questions and make sure we answer all the good ones that you've already submitted. I thought what I would do is give you a peek inside of the work that we have been doing at UCLA Health, and work that began even prior to a known pandemic being present in the United States. As many of you probably know, UCLA Health, we have a strong international program. So we do a lot with training in other countries. We receive patients not only from other states in the US, but from other countries, particularly for our highly specialized service. So in December and January, we began hearing information from our colleagues in China about what was happening, particularly in Wuhan. And so our infectious disease team and our emerging infectious disease system began being activated and following the events there. In February, we were already doing calls and the initial planning to set up our command center. And then by the first week in March, we were in full command center mode, having our disaster center set up inside UCLA Health and beginning to prepare actively for the presence of COVID-19 in the United States. And certainly, as we saw the events unfold in February in Seattle, Washington, we were working with colleagues in the healthcare industry as well. That required a lot of close coordination with World Health, with the Centers for Disease Control, and with LA County Public Health. So one of the first things that we needed to do in preparing for this is really understand how COVID-19 was transmitted. That piece was important to make sure that we could protect our staff and on our patients, and making sure we had all of our staff trained on the precautions to be taken, making sure that we had sufficient amounts of personal protective equipment, making sure that we had a surge plan so that we could quickly free up space and equipment to care for surges in COVID-19. That was a particular challenge for us because we were a health system that was already operating at 100% capacity. So we had to quickly identify how could we create beds in spaces that usually aren't housing beds? How do we quickly decant and discharge or transfer patients to free up space? So that led to a lot of things in those first few weeks of March that were atypical for health systems. So by the second and third week, we were actively postponing any surgeries or procedures that weren't urgent or emergent, so we could create that potential surge space. And the entire time working closely not only with LA County, but with the CDC and with other hospital systems in Los Angeles, so that we could make sure that we had the resources available if we began seeing surges in numbers. Now, fortunately, in our state, through the actions of our governor, and in Los Angeles, through the actions of our mayor, we implemented early measures, such as the shelter in place, that allowed us to really reduce the transmission. We also did many other things in our healthcare setting. We and other hospitals restricted visitors coming in. We looked to have as many employees as possible working from home. All of those things really helped us begin to contain. That being said, in California, and in particular in Los Angeles, a county with 10 million people, we do have high numbers, but at no time did we really have numbers that outstripped the ability of health systems to respond. So we didn't see what happened in New York, Houston, New Orleans, Detroit, and a few other key cities. To date, I wanted to just give you a little perspective on the numbers, and I'll take them from a state to a county and then specifically to UCLA Health. So as you know, worldwide, we've had confirmed now about 5,722,000 cases. In the United States, 1,700,000. In the state of California, we've, as of yesterday, had 98,980, so really quickly getting close to 100,000 cases in California. Los Angeles County represents 48,700 of those cases. And with that, in Los Angeles County, we've had 2,195 deaths. One of the things that we're watching very closely as we're looking at how we flatten the curve is the numbers of new cases in 24 hours. So every day we follow a report looking at how many new cases and how many deaths associated with that, and what is the hospitalization rate. And as many of you know, now that we have an abundancy in testing, we keep getting more numbers every day simply because we're testing more people. In relation to testing as well, I want to say that a credit to the lab at UCLA Health. In early March, we were one of the first labs in Southern California to be able to do our own COVID-19 testing. So that allowed us to do tests and get results back very quickly. The national labs at that time were ranging anywhere from 4 to 7 days. And as you know, waiting that long for a test, you can have a lot of exposures. Now we're able to do almost 1,000 of our own tests a day, and that number keeps rising. So testing is very, very important as we navigate through this pandemic. The other thing that I wanted to mention that has helped in Los Angeles is our hospitalization rate has run about 13%. So of all the people tested, right, the numbers that are hospitalized are a lot less. So getting back to the numbers in Los Angeles with 48,700 cases, about 6,200 of those people have required hospitalization at any given time. And currently, in the 125 hospitals we have in LA County, we have 1,477 patients hospitalized. So that number is manageable. And at UCLA Health, we've hospitalized a little over 250 patients total. Our peak numbers of COVID patients in the hospital at any one time were about 50 confirmed and ruling out about another 40 in that time. So as you can see, we're a system that we can surge up to 900 beds. This was taking a small percentage of our beds. What did happen though is because we all had to rapidly postpone or cancel surgeries and procedures, a health system that typically runs at 100%, we quickly dropped to about 50% occupancy. And on the outpatient side, our visits in our 180 clinics throughout the region dropped to about 50% capacity. So as a result, the financial consequences in March and April were huge to our health system. We ended up, between our hospital system and our faculty practice plan, our revenues were down by about $240 million. So you can see that sustaining that type of activity isn't financially viable. Now, however, with the ability to do testing of every patient that comes in for a procedure or a surgery or an admission, the abundance that we have or the sufficient amounts of personal protective equipment, we can safely and effectively open things back up. So we did begin rescheduling these patients about 3 weeks ago. We're now operating at about 85% of our capacity. On the outpatient side, we're still doing a lot of our visits by video visits, which many visits can always be done that way. But we are bringing back in the patients that need to be seen in person for an exam or a procedure, and we're able to safely and effectively do that. We have a universal masking procedure in the healthcare setting. So all of our staff are wearing masks. Anyone coming into the facility wears masks. And we have screening, temperature screening and symptom screening at every entrance of our hospitals or clinics so that people aren't coming in that are asymptomatic. That are symptomatic, excuse me. The combination of that really has allowed us and other health systems to restart, if you will, care to our patient population. And that's really important because you've all probably read in the news, many patients who needed to come into healthcare settings were too frightened to come in. And we were seeing, dramatic decreases in the number of patients presenting with strokes, with heart attacks. We know COVID-19 did nothing to cure those. That was really mainly driven by fear of the public. So a lot of our work now is on educating the public that it is safe to come in, that we do have precautions in place, and we don't want people to delay the necessary health care or mental health care that they need. So that's kind of a summary. Our command center operations, we closed those about a week ago because we are moving back into the normal mode. We are continuing to work closely with LA County, particularly as things start to open back up. We have to be careful and we have to prepare for a potential surge. But we feel what we've learned through the past 3 months in this pandemic, we're better prepared than ever. So I'll pause there and maybe ask Dr. Cherry if he wants to add anything in the summary, and then we'll move into answering some of the great questions that you've all posed for us. Dr. Cherry?
Well, thank you, Johnese, and you did an excellent job summarizing our journey. I think the one thing I'll mention is that we were quite prepared for this because we have a long history of a relationship with the county and with the state in managing emerging infectious diseases. So we've been a CDC-approved Ebola treatment center for some time. We've also have a grant and a relationship on emerging infectious diseases with the county, and we have a special relationship for managing unusual outbreaks that may occur, not just around coronavirus, but even things like around measles and tuberculosis that need special care and attention. And when we also are a referral center for LAX when there are unusual suspected emerging pathogens that may be be entering, the country or might moving around domestically as well. So we've had experience in drilling for this for some time, for a number of years, and preparing to be able to manage for this type of pandemic. And because of that, the team coalesced really well around all of this. We were quite cognizant when we set up our command center activities that we are the most important critical infrastructure in Los Angeles County when you think about, hospitals and clinical providers. And so making sure that our healthcare workers are safe, that they have the personal protective equipment, that we divide things in terms of hot and cold zones was really very important in terms of managing through the pandemic. The ability to safely work through this is a top priority in order to manage the community quite well. And when you're managing the safety of your healthcare workers, it means that you're managing the safety of your patients as well. And that's critically important because as Johnese has mentioned, we're very concerned about people that are not coming in to get their care. And we spent a lot of time making sure that our organization is safe, not just for acute issues like strokes and heart attacks, but also for people that have chronic diseases that need routine follow-up care as well, and including in pediatrics, where we've seen the number of vaccinations decrease as a result. So we are encouraging people to seek out care, to do their appropriate follow-ups, because our priority is making sure that our community and our patients, as well as our colleagues, are safe throughout this entire pandemic process. So thank you.
Thank you. So should we move into some of the questions? And I see some in the chat too, so we'll answer those as well. But one of the good questions that we've received is, given that a significant number of those infected with COVID-19 seem to present asymptomatic or with mild symptoms, is there any plan for UCLA Health to offer COVID-19 antibody testing to UCLA Emeriti and retirees? This would enable those who test positive to volunteer in various capacities at the hospitals and clinics and elsewhere in the community. Well, that's a great question. And I must say that, early on in the pandemic, we received so many emails from retirees wanting to volunteer and come back. And we were just so grateful knowing that you were all out there and ready to serve. We do have extensive efforts in antibody testing, and I'll turn it over to Dr. Cherry to give you a few of those details.
Yeah, and the way the question is worded, I do want to emphasize that there's really two different types of tests, really for two different types of purposes. So there's the PCR testing or the swab testing that I think everyone is familiar with, and those could be nasal swabs or nasal pharyngeal swabs. There's also oral swabs and salivary tests as well, and those are meant for diagnostic purposes. Do you have an infection, whether you're symptomatic or asymptomatic, with COVID-19? And so there's various levels of accuracy, with those tests. We use the gold standard, if you will, which is nasal pharyngeal tests. Those swabs actually have the highest degree of accuracy with regards to detecting whether or not there's active disease, whether you're symptomatic or not. The other test that is being referred to as antibody testing, and that's not really diagnostic per se, but the antibody testing is really to determine whether or not you might have had a previous history or exposure to COVID-19. And so the antibody test, if positive, meaning that there's detectable antibodies, only means that you've had a history. Right now, we don't really know whether or not if you're positive for antibodies, whether that actually affords immunity or not. So the part of the question which says, well, if I get the antibody test and I'm positive, that enables me to volunteer because I have immunity. Not necessarily. We don't know what level of antibodies are required to have immunity, and we don't know how long the immunity lasts, whether it's 6 months or a number of years. So there's studies, including at UCLA, to really determine that. Now, it is possible to get both a PCR or swab test or an antibody test at UCLA. And it's a matter of going to your primary care physician where they'll evaluate and assess you and determine what's the most appropriate test for you.
Yes, and just to let you know as well, we do have an online video visit that is urgent care. So on a daily basis, you can sign up for an online video visit if you're having any symptoms. Talk to your doctor, and then they can order the test from there. So you don't actually even have to come in if you're concerned about that. Related to that, Dr. Cherry, a general question on the accuracy of the antibody test. I know all of you have read different things in the media depending on the test. And then a question that we always get asked, can anyone just get an antibody test? Can you just come in and ask for that? Different places have different requirements. We'll cover with you how we do that at UCLA Health. So Rob, did you want to mention that?
Yeah, in terms of the accuracy of the PCR or swab testing, what we do know is that regardless of the method used, if you test positive, that is accurate. What we are concerned about, particularly in the clinical setting, is to make sure that a negative test is actually a negative test, which is why we use the nasal pharyngeal swab and a certain type of platform for testing that allows us to have a degree of confidence that a negative test truly is one. Now, as far as can anyone request one? Yes, you can actually request one with your physician, and they'll make an assessment. There's not specific criteria per se, but obviously if you're having mild symptoms that could be consistent with COVID-19, you're going to get a test just to make sure that that is not a concern. If you're getting a swab test as an asymptomatic individual, again, it's only a snapshot in time, and if it comes back negative, it only means that you're negative at that moment. The next day, you could have an exposure, not be aware of it, and actually be infected. So it doesn't mean that once you're negative, you're always negative. It just means at that time, at the moment of collection, you don't have an infection. We don't know necessarily about previous infection unless we get an antibody test. We do know that there are individuals, though, that have been exposed that have negative antibody tests. So all because you have a negative antibody test, that doesn't necessarily mean that you have had no exposure to the disease.
Yes, and that relates to another question on, will we be offering testing to asymptomatic people in the future? You know, it is one of the things that we're actually looking at with the university in the way to get students back. All universities are saying, what is it? Do we test everyone? But as Dr. Cherry mentioned, that test is only valid for that snapshot. And even to test people every 2 or 3 days with the numbers, economically, it isn't something that is feasible. So until there really is a test that is a very quick point of care, simple and inexpensive test, it's not really something that can be done, effectively to really assure that you're preventing against the transmission. Another question that came up is related, and we'll stick on the research questions, then we'll move to all the great economic questions you have as well. But when will we be able to be vaccinated against COVID-19, and who will receive the vaccinations? And we are participating at UCLA Health in a lot of the trials, not only on testing, but on vaccines and on new drugs. We actually, on our website, which will send you all a link to our UCLA Health .org/coronavirus website. We have a lot of great information on there. And then we have a separate website specifically that links to all of the clinical trials and all of the great research that's going on here. But vaccine development is something that we talk about weekly. We're talking about it with our colleagues across the country and across the world. We don't have anything that is appearing to be a quick fix at this moment. There are some trials that look exciting. Dr. Cherry, did you want to mention anything more about that?
Yeah, I think there's, growing optimism that a vaccine and even more than one vaccine, could be available in a short time frame, meaning 6 months, but it could take much longer. Nobody really has a crystal ball. I think the optimism is the number of, credible research organizations that are looking into this, the number of active trials, and the fact that the virus is actually relatively stable. And because it's not undergoing a lot of mutations, it means that the ability to actually find a vaccine is much higher in terms of the probability of success. In terms of, who's going to be able to receive a vaccine, that's a complicated question. A lot of these vaccines that we're looking at is probably going to take 2 or 3 doses to be able to get, immunity. So it will take some time period. So if you're looking at 330 million people in the country, for example, that could be 1 billion doses. And the logistics of distribution is rather complicated. It's not just 1 billion doses, it's 1 billion vials, it's 1 billion alcohol wipes, it's 1 billion Band-Aids. So there's a lot of detail really associated with that. And I think there will be an effort to make sure that the most vulnerable get vaccinated first. So those that are older, those that have certain types of comorbidities that put them at risk, or individuals that are in high-risk environments such as healthcare settings will likely be vaccinated first, given the massive sort of logistical issues that will be involved with vaccination distribution.
Thank you. Another question is asking us, how are our clinics decontaminated? Some people are really hesitant to come in, and someone is asking, is it possible to make a time slot if you need a blood test in a laboratory so that you're not waiting in lines? So first of all, I want to say in all of our hospitals and clinics, we're using the highest standards of cleaning. We're using, as I mentioned, universal masking. We're using social distancing. What we're trying to also do now is avoid anyone sitting and staying for long periods of time in our waiting rooms. We're actually trying to text people to come in from their car. Those of you who may be in a vulnerable population group, if you need specific accommodation, we're here to work with you on that. Simply convey that to your physician. And again, if there are any questions on that, feel free to email me, and I'm happy to help direct you so that you can get your care done safely and effectively for your condition. But as I mentioned, we feel right now that hospitals and clinics are some of the safest places in the community. Certainly a lot safer than, being in a grocery store or another place where other people are coming in that may not be masked, that may not have the same types of cleaning standards. So we want you to rest assured that we can get your care needs met safely and effectively. Another question is, with the national and World Health Protection agencies being underfunded or closed, what's the future at the state, county, or federal level? Well, the one thing that the COVID-19 pandemic did is bring front and center the need to fund public health. All of our advocacy organizations, particularly in healthcare, have been advocating for that. We're really hopeful that we will see some increase in funding. We know that even to get out of this current pandemic, we need to have a lot more resources, not only in testing, but in contact tracing. So I think now, we've been able to elevate this to a national and worldwide platform that people really see the value in investing. And we've all lived through the years of underinvestment in this type of thing. And I think, it's becoming something that is now really a global public health issue. So we are hopeful. We have also been, very appreciative of some of the stimulus funds that came in through the CARES Act to help us bridge some of the large financial gaps that we've seen. It isn't anywhere near what we need, but it definitely was a bridge and certainly a lifeline for healthcare organizations across the country. With that, I want to segue into the chat where people are asking a lot of questions on the finances. And so to let you know, certainly we're working very hard at UCLA Health to safely and effectively restart the patient care so that we can return to the normal volumes of patients that we're staffed for. The University of California as a system, you all are probably aware of this, President Napolitano and the 10 chancellors issued a letter in March really saying that there would be no layoffs of any UC employees through the end of June. That letter was sent out. There really hadn't been a financial calculation of that. We're all really seeing the effects of that, but we had definitely committed to keeping employees employed. So for us, that meant a lot of people working from home, getting paid from home, and if we didn't have work for them, there are various types of leaves that are available. After we get through the end of June, though, we really have to evaluate our financial position at each campus, what type of volumes we've returned to. We've made a commitment to really look at any efficiencies we can in the non-labor categories so that we can really stay staffed and stay prepared to return to full occupancy. So our whole leadership team here at UCLA Health is working very hard on that. Of the CARES funds, we did receive about 54 million. I mentioned we had about a 240 million drop in revenue, but we've received about 54 million in those CARES supplemental payments. So that has helped us navigate a little through the situation. And we're pleased at where we are right now. In the month of May, as I mentioned, we've returned to about 85% of our volume. So we're really hopeful that we'll be able to navigate forward through this crisis. Next, there are questions regarding mortality rates. That's going to be a tricky question for us to answer because we've certainly seen different mortality rates across the country. I was on a CEO call last week with our colleagues from New York, and the New York Langione Medical Center system had 6,000 COVID admissions. They had almost 1,000 deaths. So they really were hit significantly. Here at UCLA Health, I mentioned the 250 we've admitted, we've had a little less than 20 deaths. Most of the deaths that we've seen are in elderly patients with pre-existing diseases. So that's just kind of a snapshot of where we are. But the overall mortality calculations are still being estimated. Dr. Cherry, did you want to add any more to that?
Yeah, the mortality rates, some things are kind of obvious and consistent with other diseases, older age and comorbidities that tend to put individuals at risk. I think, what's a little bit different about this particular virus is that it's not just a pulmonary disease. It seems to be impacting, other organ systems as well, but to varying extents. So you can have someone that's an asymptomatic carrier to someone that is, severely ill in a critical care unit. And people are trying to really understand that. You could have neighboring states and neighboring countries with very different impacts in terms of the disease. So there's a focus in also understanding why the differences. There's a lot of research going into genetic differences between individuals that might account for this. There was an interesting preliminary study released in which a particular gene that's a marker for Alzheimer's disease seems to increase the risk of mortality. So it's not necessarily Alzheimer's disease per se, but something about this particular gene that may be impacting the immune system to make those individuals much more vulnerable. So I think there's a lot that we don't know right now about what's impacting the mortality rates. That's under a lot of clinical investigation, both in the basic science world and the clinical realm as well. But in terms of your own personal protection, it's a matter of exercising a lot of common sense. It's the social distancing, it's the frequent hand washing, it's not putting yourself necessarily in high risk situations unless it's necessary. If you have to fly, fly and it's necessary, you should fly. But you want to be more cautious if you're older and do have other, chronic conditions. But at the same time, you do want to live, and you do want to be able to, communicate and stay in touch with those that are important to you as well.
There's another good question in the chat regarding someone being concerned about coming in for surgery because they can't have their family member. That definitely has been a big issue. I must say, I think the effects of this on hospitalized patients of not having their loved ones be able to be with them all the time has been a challenge. And I'm thrilled to say that we are now able to open up visitation again at UCLA Health. We will be allowing every patient to have one visitor. That visitor will be screened when they come in. They will be given a mask. But we really are at a place now where we can do that, and that will go a long way to comforting some of our patients. One of the things we did in the interim is we did have iPads in the room so we could do video chats with family members. Our pet therapy team, which we've had to keep them out of the hospital during the pandemic, patients could also schedule a Zoom visit with one of their favorite pet therapy dogs. We've been trying to do as much as we can, but nothing replaces having a loved one with them during the visit. And we recognize that, and we're really thrilled to be able to do that. We'll be sending a communication out to our patients this week, letting them know that. So please reassure friends and family if they have that question that we are continuing to evolve these policies to return to our truly patient-centered and family-centered environment at the same time while keeping everyone safe. There's another question in the chat about healthcare workers. That's certainly been a big topic nationally about how many healthcare workers are infected. At a high level, I will say one of the trends that we're seeing is that if healthcare workers are becoming positive, usually more than half the time, it's them getting positive from an interaction in the community rather than in the healthcare setting. And we haven't had reported transmission related to breaks in PPE. So that's kind of in general where we are on that. Dr. Cherry, did you want to give any other details related to that?
Yeah, I think the important thing is that we are encouraging everyone to be very proactive. So we have, available on our phones and through our computers, a daily survey that we complete where we essentially answer questions about whether we're having certain symptoms or not, or a fever at home. And if we answer those questions in a favorable fashion, we get an electronic certificate that basically says we're okay to enter the building. If for some reason individuals have not, completed it at the time, then they're asked questions upon our entry sites, whether it's our hospitals or clinics. Do you have symptoms? And there's automatic temperature taking as well. Individuals that may be having symptoms, that they're referred to our call center. They get an evaluation. Sometimes they get testing just to make sure that they're okay before returning to work. So we have a whole program actually in place to make sure that workers that are not feeling well complete these surveys and stay at home if they're not, and reach out to our call center to determine what the next steps are. That's worked tremendously well for us in terms of keeping our clinics and our facilities safe, so that people feel comfortable coming in and knowing that our environment is not one where it feels unsafe because there could be multiple sources of transmission.
Thank you, and we'll answer a couple more questions in the chat, and then I'll also turn it over to Michael Healy, as I know he has a group of questions for us. But first, Dr. Cherry, is it advisable to have an oximeter at home to monitor your oxygen levels?
Yeah, Johnese, we've been at a lot of different town hall meetings, and this one's really actually an interesting one. And I'm not sure what the driver is behind the question, but there are reports, and I think many of you may be aware that there are patients at home who are developing with their COVID-19 disease progressive hypoxia or low oxygen levels. And they seem to be relatively stable at home, maybe breathing a little harder, they're not noticing it until you actually put a pulse oximeter on them and the low oxygen levels are actually visualized. It's unusual. It's not common that people at home are actually have those low oxygen levels, and so that could be prompting the question. However, I wouldn't recommend that everybody go out there and purchase oximeters and monitor their oxygen levels. I think that really should be reserved for really high-risk individuals, and I'm not talking about just age and comorbidities, but those individuals that are in institutional settings like skilled nursing facilities. There's a lot of value in getting daily vital signs as well as oximetry readings on oxygen levels, because the testing there unfortunately has been more limited, and early hypoxia could be a warning sign that there's a COVID-19 infection. But I don't think it's routinely necessary actually in the home environment. We do know that in Los Angeles County, approximately 50% of the deaths are related to those that are in institutional environments such as skilled nursing facilities. Those are the individuals right now that are at the greatest of risk, and therefore could probably benefit from routine pulse oximetry monitoring.
Thank you. The two other questions in the chat. One is, have we seen any of the children with the multi-inflammatory syndrome? We've admitted one child to the Mattel Children's Hospital that was being ruled out for that. And then the other question is about how many patients require ventilators. Of that 250 that I mentioned we've admitted, about 1/3 of those patients have required some ICU stay and some time on a ventilator. One of the good news is, I will say, is a lot of our ICU patients have been safely and effectively discharged. That group of patients who have expired, most of those, again, related to the group that Dr. Cherry just mentioned. And then with that, why don't we open it up to Michael to see what questions he has for us.
All righty. Thank you both, Dr. Cherry and Ms. Spisso, for joining us today. I have received a couple of questions regarding return to the old normal. For example, will employees who have been working remotely be tested for COVID-19 or COVID immunity before returning to work? And will temperature checks be required for all employees when reporting to work each day, obviously to ensure the safety of the workforce?
So I'll start on that. Yes, we will be continuing to monitor temperature checks. In addition, for our own employees, we have a Qualtrics survey that can be filled out every day on your iPhone that asks you, have you had any symptoms? Has anyone in your family been tested positive for COVID? And then you get a little badge that kind of shows you cleared to work. We already have about 9,000 employees who are using that on a daily basis. As far as the working from home, you've probably all seen the university extended the working from home ability through the second week in September. Right now at UCLA Health, we have about 3,500 of our employees working from home. We are extending their ability to work from home through that second week in September. And what we'll do then is evaluate them coming back. And a lot of these are in places like finance, IT, and as they come back, we also have to modify the work setting to make sure we have the 6-foot clearance between cubicles, that we don't have more than a few people in the elevator at one time. So we may continue keeping a lot of kind of back office functions working from home until we know more about this pandemic. On the testing side, I'll turn that over to Dr. Cherry, because we have not made a decision or rule to test everyone before they come back. We haven't gone to that yet. Rob, did you want to mention anything else on that?
Yeah, and I think the reason why is we don't really understand the testing well enough as a decision tool for a return to work guidance, particularly antibody testing. We do have a large trial going on right now where we're enrolling up to 4,000 healthcare workers in a trial that will watch them over a period of a year, where every 2 weeks they get the PCR or swab testing, and then once a month get serology or antibody testing. This will allow us to understand what the prevalence of the disease might be, and to more accurately understand the relationships between the level of antibodies that an individual might have and degree of immunity or protection that they might have. So there are other studies like this going on around the country, and I think as we get more information, we'll be able to understand with much better precision the relationship between testing and return to work.
I see. Does that extend to, say, all the campus staff? I know there's an enormous number of people that work at UCLA, but in facilities, in offices, administrators, and you were speaking of the healthcare system, but what about the rest of the campus?
Yeah, and it's not just the rest of the campus too. It's really everybody within our community that's thinking about this, and the study is just that. It's a clinical trial meant to understand antibody testing, but it's not used as a return to work guidance. However, those individuals that happen to test positive, they're reported out to both the county and occupational health, and then clinical next steps are determined. It's rather difficult to understand exactly what to do within the campus setting, given the volume of individuals that work on campus and the limited number of testing, and the fact that with the swab testings, which are diagnostic, is only a snapshot in time. I think what we really want to understand is the antibody testing, and also how to apply testing to really high-risk groups, such as those that are, student athletes, for example. How do they practice daily to make sure that they're also safe as well? So there's a lot of behind-the-scenes discussions about that. But for the general campus community, there's a lot of effectiveness to really implementing hand washing, having hand sanitizers and wipes available, practicing social distancing, where appropriate to do remote learning. So there's a lot of techniques and strategies that can be done that may eliminate the need for large-scale testing in the way that you're describing.
Yeah, and there's a question in the chat, related to that, about what changes are being contemplated at the university for dorms, for large classes. There's a lot of planning going on with that, not a lot of easy solutions, particularly, as many of you know, some of our dorms are triples. So, we have a lot of planning to do in order to safely resume the normal operations of our campus.
Indeed. Okay, let's see. Stephen, have you gotten anything that you'd like to ask while I search for some more?
I think that in the interim, I just want to thank Ms. Spisso and Dr. Cherry for this session. It's really an introduction to this group of very interested and engaged people, albeit retired, and who love the UCLA campus. That's really the mark that unites all of the people who attend these lectures. And this was a wonderful start to enlightening us and to bringing the problems that you're facing to the fore. And in the coming months, we're going to try to have other programs that will continue to let this UCLA community that's so engaged understand how the campus is going to change and how the health care system is going to have to adapt to all of these things, and how it's possible that some of your favorite people may not continue to work here anymore, and that may be a sad consequence of the world in which we live. Do you have any final words, Dr. Cherry or Ms. Spisso?
Well, we just want to thank you all. You're all really our ambassadors in the community, and thank you so much for your support to UCLA Health. We're happy to do another one of these in the future as this pandemic evolves, or if you want other members of our team who are experts in the work being done on the research side, we're happy to help arrange that for you. But thank you all for your interest and for your continued support of UCLA.
And thank you, and you're quite welcome. With that, I think we'll conclude the program unless Aisha.
No, I don't have anything further. I just heard about the student that was just tested positive on the Hill. So I was thinking and wondering how that's affecting, since he or she is currently living on campus. But I'm sure that story is just evolving. And I think the student's quarantined somewhere on campus. So if you can answer that question, then maybe we can just wrap up the program.
Well, I don't have a lot of information on that, but we do have procedures in place where there's areas on campus where individuals can self-isolate and quarantine, both on the main campus as well for any healthcare worker that's concerned. So there's already arrangements that's already in place for that. And just final comment to everyone. I want to thank everybody for their really thoughtful questions. In addition to taking care of yourselves physically too, is also important to take care of your well-being and mental health, and make sure you do connect with people and rely on your support groups through what is a really difficult time for everybody. And again, thank you for all of your time, your dedication, and commitment to UCLA.
Yes, this was wonderful. I really appreciate everyone. I'm unmuting all the participants. So thank you all for attending. I'm going to send all the recorded session to get, hang on one second. Let me actually, okay. So I'm going to send the transcription over to Michael Heafy and Steve Cedarbaum so they can transcribe it, and then that'll be sent out periodically. So as a registrant for this program, you'll get an email with the PDF of all the questions and answers. We'll definitely do something more in the future. Hopefully this Zoom program worked well for everyone. I don't think we had too many technical difficulties. So really excited to bring you more programming like this. Again, thank you to the Emeriti Association, the Retirees Association, and the folks from UCLA Health System. I really appreciate us coming together. So it's a great morning. Hopefully you all have a great weekend. Thank you. Have a great day.
We are leaving the meeting. Bye.
Okay.
We want to leave this meeting. Leave the meeting.
I
Are
see
we
you
leaving?
still.